Your first patient of the day has chest pain and shortness of breath, and you're wondering, do they have a pneumothorax?
And then you get called to the PZD for a patient with a fever and a rash. You wonder, is this just a non-specific viral rash or something more insidious?
In this episode of Critical Decisions in Emergency Medicine, we will talk about the management of pneumothorax, both spontaneous and traumatic.
We will also talk about pediatric febrile rashes and how to characterize them, as well as some important diagnoses to consider.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the March 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine, or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the Critical ECG, and as our listeners know, one of my favorite, the literature review.
And for our first lesson of this issue, we have Clear the Air, Pneumothorax Management, written by Dr. Hassan Al-Shaqqaq and myself. And I am grateful to have our lead author here with us. Dr. Hassan, welcome to the podcast.
Thank you, Danya. I'm glad to be here.
So Hassan, what prompted you to focus on this topic?
This comes frequently in the emergency care, and there are still gaps in recognition, as well as variability in management that often can impact outcomes. This is particularly interesting where we are moving from an old practice of invasiveness and the beloved large bore chest tube, which are fun for trainees, but not so fun for the patients, to an era of more patient-friendly and minimally invasive management plan.
Well, then let's start by going over some definitions and classifications.
Pneumothorax can be spontaneous or traumatic, and spontaneous is either primary, where there is no underlying lung disease. Think about it, especially like your young, tall patient who is a smoker. Spontaneous is either primary, where you don't have underlying lung disease. Think about it like your young smoker, tall patient, or secondary, where there is underlying lung pathology, like patient with COPD. Traumatic pneumothorax can be either open, meaning there is defect through the chest wall, or closed, where the chest wall remains intact. An open pneumothorax, also referred to as communicating or often called sucking chest wound. Then there is a tension pneumothorax, which is a life-threatening form and can be seen in any of these mentioned types. Tension pneumothorax is characterized by mediastinal shift, venous compression, as well as hemodynamic instability.
That makes sense. Now, what about how do we diagnose this clinically?
So this is typically a sudden presentation with shortness of breath and chest pain. And it's really important to realize that the symptom severity does not necessarily correlate with the size of the pneumothorax, but rather with the underlying physiology and cardiopulmonary reserve of the patient.
That makes sense as well. So what about radiographically? How do we make this diagnosis?
Ultrasound is often the initial imaging modality, especially in the emergency setting, where the probe is our beloved toy. It's quite sensitive, around 91%, and highly specific. Key findings include absence of pleural sliding, absence of P lines, as well as the barcode sign on an M mode, the lung point as well. The chest X-rays are more commonly used, and they are less sensitive, around 40%, but still quite specific. And radiographs can be helpful in measurement. One for interpreting supine films is to look for the deep sulcus sign, which is particularly useful among critically ill supine patients. And while CT is not routinely indicated, it can be useful in select cases, such as distinguishing a pneumothorax from a large pulley. However, it's critical to know that tension pneumothorax does not need radiological confirmation before proceeding for intervention.
Absolutely. Ultrasound is definitely a great bedside tool and provides us a timely diagnosis. So how do we manage a spontaneous pneumothorax?
There are several management options, such as conservative management, that is oxygen and observation, and interventional drainage, which include 3 options: either needle aspiration, insertion of a pigtail catheter, or tube thoracostomy. And the choice is mostly guided by the patient clinical status, the size of the pneumothorax, as well as prior history of pneumothoraces. For primary pneumothorax, the British Thoracic Society recommends minimally invasive strategies whenever clinically possible, focusing on decision-making on the patient's symptoms and clinical stability rather than on the size of the pneumothorax. So, if they are hemodynamically stable, healthy, with minimal symptoms, then conservative management is appropriate. Stable ambulatory patients with spontaneous pneumothorax with no progression on repeated chest X-ray can be discharged as long as follow-up is ensured within 24 to 72 hours. On the other hand, if symptoms are significant, then the patient should undergo pleural drainage with a needle aspiration or pigtail catheter. The exact choice is controversial, especially for first-time lodged spontaneous primary pneumothorax, and therefore, decision-making with the patient is recommended. Those with secondary spontaneous pneumothoraces typically require an intervention with either pigtail catheter or tube thoracostomy because of the impaired underlying pulmonary function.
That makes a lot of sense as well. So, what about tension pneumothorax? You mentioned that we should intervene urgently. What do we do?
So, tension pneumothorax management starts with either needle decompression or immediately a finger thoracostomy as a temporizing measure. And the definitive management requires chest tube placement. I know we always talk about needle decompression, but what we don't talk about as much is how now we should be doing it in the fourth or fifth intercostal space at the anterior axillary line, which is currently in the ATLAS guidelines, rather than the classically taught technique in the second intercostal space. The good thing about a finger thoracostomy is that if you were to do it, then you can use that same location for your definitive management of the chest tube.
That is a very good pearl, for sure. Are there any differences in our management of traumatic pneumothorax?
Yes, definitely. The majority of traumatic pneumothoraces require tube thoracostomy. It's definitely indicated if the patient is unstable, even if the instability is related to other injuries. In stable traumatic pneumothorax, a pigtail catheter is non-inferior and less invasive. In addition, observation may be appropriate for hemodynamically stable patients with occult or small traumatic pneumothoraces, such as those with less than 2 cm on chest X-ray. However, if they are transported via air, they would need chest tube placement to prevent in-flight tension pneumothorax. As for the size of the tube, the Western Trauma Association recommends the use of the smallest tube possible for pneumothorax. And with a hemothorax, that probably needs a bit larger tube, but 28 French may be appropriate. If it's an open traumatic pneumothorax, like a second chest wound, then a 3-sided occlusive dressing would be needed until the chest tube is ready to be placed. Then it's replaced with an occlusive dressing.
An important pearl here is that prophylactic antibiotics are recommended in all patients with traumatic pneumothoraces.
That was a great summary of the management. What are some key considerations in disposition and follow-up care for these patients?
Disposition is guided by what the management strategy was chosen, which depends on the type of pneumothorax, the patient's hemodynamic stability, as well as the reliability of outpatient care. An important thing to remember for those we discharge from the ED is that flying and diving must be strictly avoided until the pneumothorax resolves. The British Thoracic Society specifically states that no flying for 7 days after full resolution, and they permanently discourage scuba diving unless definitive treatment has been performed.
Those are also really great pearls. I don't think I always remember to ask about flying or diving after seeing one of these patients. Well, thank you to our authors for being here to share the great pearls from this lesson. Definitely take a look for much more information within the article itself. I think it's always good to refresh on classifications of pneumothoraces because certainly that can drive some differences in management. But remember that The size of a pneumothorax may not correlate specifically with severity of symptoms, since that is dependent on the patient's underlying physiology. And I think it was a great reminder that now with needle decompression and finger thoracostomy for tension pneumothorax, remember in ATLS guidelines, we're now recommended to do this at the fourth or fifth intercostal space at the anterior axillary line. So take a look at the lesson for more pearls.
Moving on to the critical ECG. Recurrent syncope in a patient with gastroenteritis who also happens to have a history of paroxysmal AFib. The patient says that she's had multiple episodes of syncope, several of which were immediately preceded by palpitations. And of course, one of these episodes happens at your triage. You get an ECG, and you get this fabulous ECG that gives you palpitations that shows a torsade de pointe subtype of polymorphic ventricular tachycardia. The monitor, both prior to and after the paroxysmal VTAC, shows a prolonged QT of 540. This article goes into the detail of how to specifically diagnose torsade de pointe, what it means, why it looks the way it looks. And a great reminder in this article is that although torsade de pointe by definition has to happen in somebody with prolonged QT, in clinical practice, it is multifactorial. So they would have an electrolyte disturbance causing that, plus being on a QT interval prolonging medication rather than just one or the other. Great refresher on this super scary arrhythmia.
Scary indeed. Whew. Now moving on to our clinical pediatrics this month. It is a case of a 15-year-old boy who presents with chest pain and shortness of breath with a recent URI type symptoms. So got treated as acute sinusitis in the outpatient setting, but comes in for persistent symptoms. And you find that he is tachycardic to the 130s. Ultimately, the workup shows that he's positive for Mycoplasma pneumoniae, but you also get a CT-PE study that shows a large PE, which was a surprise, maybe.
So definitely a surprise because pediatric venous thromboembolism is exceedingly rare. And thankfully, most PEs found in children, so 2/3 of them, are non-massive. When we think of risk factors for PE in children, they're similar to those in adults. And because they're less common in children, then therefore PE is less common. A couple of things we got to think of, though, in this population is that they're more likely to have congenital clotting disorders that can put them at risk that we don't know about. And then there's some infectious organisms like Mycoplasma pneumoniae, like in this case, that can increase that risk. And research into that is actually quite minimal. An important risk factor that we got to think about as well in kids is the presence of malignancy and the presence of a central venous catheter, because that is present in around 2/3 of cases of venous thromboembolism. And hospitalization is a big risk factor in that population as well.
Definitely. In terms of the workup and management of these patients, unfortunately, the D-dimer and the Wells score are not as useful in children. And so if you have a suspicion for this, you should obtain a CT-PE study in this case, or you can consider a VQ scan. Treatment, though, is just like adults, anticoagulation.
Our literature review this month is of an article by Monroe et al. Entitled Peripheral Vasopressor Use in Early Sepsis-Induced Hypotension that was published in JAMA in 2025.
Yeah, this is an interesting study because I don't know about you, Danya. At least I feel like we are trying to move away to less and less use of central venous lines. And so it's nice to have evidence to maybe support its safety and non-inferiority in a way. But specifically for this study, it was a secondary analysis of the Clovers trial, which looked at crystalloid versus vasopressor use in early resuscitation and sepsis. And so in the subgroup analysis, they were looking at patients, of course, who got vasopressors started peripherally versus centrally. And they found that those who had vasopressors administered peripherally had a low rate of complications, about 0.6%. And those who ultimately did receive a central line within the first 3 days, they had a complication rate about 3.7%. So certainly not zero risk, but generally low. And there's no difference in overall outcome in terms of mortality. So I think there's growing evidence that a short-term use of peripherally administered vasopressors can be done.
Definitely a great article that adds to our comfort in this practice that as you shared, Wendy, we're trying to move away from the central access when it's possible. For our critical procedure this month, we have ultrasound-guided subacromial injection, and that's usually done for tendinitis or bursitis as an adjunct for pain relief. The idea is to inject a mixture of corticosteroids for long-term anti-inflammatory effects and an anesthetic for the immediate but temporary pain relief. Take a look at the details and the images in the article.
Now, in terms of our critical cases in orthopedics and trauma this month, it's actually a case of sternoclavicular joint septic arthritis. And there were some great pearls that I learned from this case, such as the fact that the sternoclavicular joint is actually a fibrocartilage joint, not a hyaline cartilage joint. And this is important because apparently predisposes the joint and the surrounding tissue to infection because of pressures at that joint's mobility. Unfortunately, this type of septic arthritis is frequently missed because its presentation may include a rash or chest pain that radiates down the left arm that may lead us to other workups like for an MI. The gold standard is actually MRI because it can show deeper collections of infection, including mediastinal complications. But if you don't have access to it, certainly CT is a good alternative. Ultrasound can be useful, but X-rays really don't help us in this case. Oftentimes, when we're worried about infections such as in septic arthritis, we may utilize some lab studies like ESR and CRP that may help us just to further risk stratify. And in these type of infections, you're actually worried about a number of organisms, whether staph or strep. And so you're generally treating with broad spectrum IV antibiotics for 4 to 6 weeks. And then in very severe cases, of course, you may also even need surgical debridement.
For our critical image this month, it's a case of a 21-year-old man who comes in with a sore throat and has increased pain with swallowing. Comes in, relatively normal exam, and then they get imaging and realize the patient has epiglottitis. A very scary diagnosis indeed.
Absolutely. Thankfully, with the introduction of the Hib vaccine, certainly it has decreased the incidence as well as the mortality related with infections like this dramatically. Worthwhile to take a look at all the images in this particular case.
What I personally found really interesting was what made these physicians do all of this imaging for somebody with just a sore throat. And the big pearl here is if somebody says they have a lot of pain and their exam is really normal, then you really got to think about epiglottitis because that may be the cause.
Good reminder.
So for our second lesson of this issue, we have Scratching the Surface, Pediatric Febrile Rashes. Thank you to Drs. Jared Grimm and Rachel Wiltshire for writing this article. You know, Wendy, I don't know about you, but pediatric febrile rashes are really not what I want to be looking for in the emergency department. One, I have no idea what I'm looking at. And two, the news is always filled with something horrible that is on the rise. And I don't want it.
Yeah, I know. Unfortunately, they're quite common. Up to 14% of ED visits are related to skin complaints, which are mostly rashes. So we cannot get away from this. We have to learn about it.
All right, let's learn a little more about this together. How do you characterize a rash? I know that some of us now just even don't bother to write about the rash. We just take a picture and put it in a chart. But what if we cannot do that? What if we actually have to use words?
What if we have downtime?
That is scarier than pediatric rashes.
True. Well, I think all of us are familiar with macular rashes and papular rashes. And sometimes, I guess, some people describe them as both, but there's a lot more descriptors than that. Essentially, I think that there's some great pearls in this lesson about how when we're describing rashes, we might think about the texture, the color, and of course the shapes, the distribution. And then are there other sort of skin findings like blistering, blanching, or clustering? And so based on that sort of descriptor, I think we can be better at describing what we see. But as a quick refresher, flat, non-palpable lesions are things like macules, whereas raised palpable lesions are things like papules. And certainly if they're fluid within the lesions, we think about vesicles and bullae. Maybe there's also some erosions or ulcerations. And there can also be localized hemorrhage like petechiae or purpura. So you now have a lot more adjectives. But another important reminder is that a same type of a rash can look very different between patients, especially with patients of different skin tones. And so over the years, we've definitely been making more of an effort to better characterize these rashes according to skin tone. But I think being cognizant of that being a potential limitation or sometimes bias is important.
Definitely a great reminder, Wendy. So, in addition to actually looking at the rash and describing it, we know that historical elements can be really important to identify the potential triggers and risk factors. What are some common and notable etiologies of the rashes that we have to consider?
Obviously, the list of conditions that can present with a febrile illness and rash is very long and oftentimes benign, just related with some sort of a viral illness. But a few of note that I think we have to be extra mindful of because of potential complications or contagiousness and such are measles virus, obviously in the news, and this typically develops several days after the onset of fever, and it's classically a macular papular rash that is descending. And they also may be associated with those cope-like spots. That's quite pathognomonic. And of course, we worry about long-term sequelae like immunosuppression and neurologic complications. We also worry about parvovirus B19. This rash also occurs about a week after the illness onset, and the classic presentation is that slack cheek appearance of eruptions on the cheeks. Or patients can also have these papular purpuric gloves and socks syndrome that occur in older children. And so the importance in recognizing this is that it can cross the placenta, so affect pregnant individuals, like staff members should be extra cautious and avoid caring for these patients if we're suspicious for it. Coxsackie virus, we know, is responsible for hand, foot, and mouth disease. And so these are generally vesicular lesions that, like the name suggests, occurs on the hands, feet, and mouth, but can also be found on the buttock and the genital areas. This is also quite contagious and spread primarily through the fecal oral route, so we have to counsel families on this. Also, roseola, we may not talk about this much, but this is caused by human herpes virus 6 or human herpes virus 7. And this particular rash that is characterized by small blanchable papules, it's mostly on the trunk. There can also be oral cavity lesions called Nakayama spots. This is generally self-limiting, but there can be some rare cases of disseminated infections that can cause severe neurological dysfunction too. And then also, we talked about a number of viruses, but don't forget bacterial infections can be associated with rashes. And one reminder from this lesson is disseminated gonococcal infections, which is associated with high morbidity. And so if you're dealing with maybe particularly neonates, an infant born to a mother with a gonococcal infection that was known or not known, these patients can present really sick with microabscesses, a variety of rash presentations that affect the trunk, hands, and feet, or also even gonococcal pharyngitis.
Wow, that's a lot of things that we need to keep track of and think of. Well, you did mention that some of these rashes are associated with illnesses that have potential long term complications. Any additional deadly rashes that we need to be aware of?
Yeah, I think the previous list was talking about these overall infectious condition itself being potentially associated with the long-term complications. But I think when we talk about quote-unquote deadly rashes, this is the category when we're talking about staph scalded skin syndrome, toxic shock syndrome, meningococcemia, necrotizing fasciitis, and Stevens-Johnson syndrome, as well as toxic epidermal necrolysis. So a few refreshers on these conditions. Remember that staph scalded skin syndrome, this is generally a very rapidly progressive desquamating erythematous rash, and the people can have sloughing, slipping of the epidermis from the lower skin layers, which is what the Nikolsky sign is. Remember that toxic shock syndrome, typically associated with group A strep and staph infections, essentially people present with a massive cytokine release SIRS response. And these are also associated with a diffuse erythematous blanching rash that can ultimately, in a few days' time, also have desquamation, so initially present more of that erythematous appearance. Meningococcemia has that very distinct hemorrhagic rash that really presents mid to late in the disease. And so when we see it, we better recognize it. And this is that dark purple purpuric non-blanching rash that can involve the hands, feet, and mucous membranes. Necrotizing fasciitis, I think this is something we definitely encounter and have high index of suspicions for often when we're dealing with infection symptoms and pain out of proportions. But really, the skin findings present much later, whether it's the induration, erythema, shiny appearance as that spreads before it becomes the dusky, purpuric, gangrenous late stage findings. And finally, in terms of Stevens-Johnson syndrome and toxic epidermal necrolysis, this is a spectrum, really. And we describe SJS as less than 10% of the body surface area being affected, and TN when more than 30% of the body surface area is affected. And this is also a condition that is more of an immune response, oftentimes related to some sort of trigger like a medication. And patients can have widespread tissue necrosis within 3 to 4 days after whatever the precipitating inciting agent may be.
Definitely a scary topic. So how should we manage these patients?
Mostly, it is going to be supportive care because we're dealing with, of course, a wide range of etiologies, and then particular treatments that are targeted at the underlying cause. Maybe for measles patients, sometimes we worry about malnutrition or vitamin A deficiency, as well as thinking about whether patients may need post-exposure prophylaxis, or rather, those close relations may need post-exposure prophylaxis to some of these conditions. But don't forget that sometimes patients may need a good amount of volume resuscitation if they're coming in with maybe toxic shock syndrome, a Staph coated skin, or SJS. And then we need, of course, our surgical colleagues involved with necrotizing fasciitis.
Well, thank you, Wendy, for reviewing this incredibly important topic. We talked about febrile pediatric rashes and how to describe them, what relevant history we need to take, and the fact that although most of them are just viral exanthems that are not scary, some viruses are scary, like measles, Coxsackie virus, chickenpox, especially in older kids, and how rashes can also be non-viral, like toxic shock syndrome, staphylococcus scalded skin syndrome, meningococcemia, necrotizing fasciitis, and Stevens-Johnson's and toxic epidermal necrolysis. Kawasaki as well is something we got to think about. And of course, each of these would need to be treated differently.
Absolutely. This is a great lesson to keep on as a resource to refer to for the wide range of rashes we can see. Now, for our drug box this month, it is on flucytosine, which is an oral antifungal agent that we primarily use in combination with other agents for severe systemic fungal infections, most commonly with amphotericin B, treatment of cryptococcal meningitis in invasive candidiasis. In terms of some particular considerations, there is associated risk of hepatotoxicity, peripheral neuropathy, and it is pregnancy category C. And it is contraindicated relatively for patients who have severe bone marrow suppression. Thankfully, there's a way to monitor the drug level that can help you monitor and walk that fine balance between therapeutic versus toxicity.
And last but not least, our Tox Box this month is nickel carbonyl toxicity. It's a volatile and highly toxic liquid nickel compound, and when it decomposes, it turns into metallic nickel and carbon monoxide. It is very lipid soluble, which basically means it is rapidly absorbed by the lungs and distributed across the body systems. An important thing to remember is that symptom onset ranges from less than 1 hour to up to 1 week after the exposure. And that is why when we're trying to figure out what to do with these patients, not only do we depend on the symptoms, but also the amount of exposure so that we can know if we need to be worried about a delayed presentation. Interestingly, you can actually get an 8-hour urine nickel level, and that can help in some of the patients. And of course, in any patient that comes in, decon is very, very important. If you need to give them a chelating agent, there's a specific one for that. It's called diethyl dithiocarbamate. And I think this was my proudest accomplishment of the day, is that I did not stutter and I just said that once. However,
Do it again.
no, do not jinx me. However, if you don't have access to DDC, then you can give them disulfiram.
Very interesting.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, I hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle on Instagram is @Dr. Danya Khoujah.
Mine is @Dr. Wendy Chang.
And until next month,